May I now invite Mr. Marcus Ranney. He's a founder of Human Edge India. So as a founder of Human Edge, he is advancing personalized longevity protocols using blood and digital biomarkers. Dr. Ranney?
All right, good morning. Thank you. While they're doing the technology, how many doctors do we have in the room? Physicians? Cool. We've heard a lot over the last few days from various stakeholders. We've had technologists and engineers, investors and entrepreneurs, policymakers, and all of the efforts that are going in to elevate this ecosystem. But I thought what I'd spend time this morning is representing the voice of the physician. Because in many ways, we are the front line implementing and translating and hopefully creating the right set of interventions and engagements to drive clinical outcomes in individuals. Now, 2 days ago, Deepak made a very interesting introduction for me to his son, who is obviously a much younger, black-haired version of him. And he introduced me as the oldest longevity physician in India. Now, I assume that was a compliment, and I assume it was because of the tenure of practice and not my biological or chronological age. But over that period of time, it's been interesting to see how this whole movement has taken shape. And what I want to do today is talk to you a little bit about how the data, or the doctor, will see you now. So, any Star Trek fans? Yeah, good. Hopefully, you will appreciate this image based on my last title. 7, 8 years ago, actually, on a stage very similar to this in Surat, I was asked to give a talk on what the future of health would look like in the year 2030. It's a TEDx talk. It's been seen now maybe tens of thousands of times. And in that opportunity, I sort of dreamt and presented this idea that by the year 2030, we will all have a digital intelligence residing on a mobile device in our pockets, constantly analyzing the streams of data and then ultimately creating the right nudges and interventions. I'll remind you that at that period of time, Siri had just been introduced, Alexa didn't exist, and Sam Altman was still at Y Combinator, right? So there's no dream of LLM or OpenAI at the time. And it's been incredible to see how this journey has advanced so far, so fast. And it's not 2030, but we're still only in 2025. So how much more can we potentially do over the next few years? So as the team and I sort of got together and we discussed how do we scale and augment the doctor in this process, because the doctor-patient relationship is a very sacred one and needs to be core in our progression towards living healthier and longer, we thought about what a potential approach would be. So what I'm going to present for us today are what are some of the bottlenecks that we faced getting here? What does a solution look like? And I say a solution because I think like Prashant and Raj spoke about earlier, there probably are many ways of solving for this. And we've heard many of them already over the last few days. And then finally, what are some of the green shoots of results that we can see? Because irrespective of the model, we must always be focused on the clinical outcome. Do no harm, and then lead to better health for individuals. So let's look at some of the challenges first. The first is the paradox of excess to scarcity. So what I mean by that is every single day, hundreds of millions of data points are being created across knowledge platforms and social media platforms, which is frankly creating a lot of confusion and overwhelm. Should I intermittent fast or should I not? Should I take a cold plunge or should I not? Should I have red wine and resveratrol or should I not? Actually, the answer to that last one is a little bit easier. Sorry, David. So in the excessive world of content and information, we paradoxically also have a situation where there's a deep scarcity of individuals who can interpret that in the right way to lead to the right outcomes for the individuals. Now, this definition of longevity physician is a very loose one. Most of us who exist in the space, like I, straddle between high-performance sport and functional medicine. But I'm sure many of the hands that were raised are from endocrinology, diabetology, lipidology, cardiology, functional nutrition, exercise medicine, health coaches, and sometimes just good-willed evangelists and ambassadors who are now trying to build part of the movement as well. So in the US, there are less than 2,000 functional trained medics. In India, there are fewer than can fit on a WhatsApp channel. That's how many of us there are, right? So with all of this information and this bottleneck of individuals potentially to be able to interpret and provide, how do we then expect the individual to get impact? Because there's also the other complication of the advancement of wearable technologies and consumable technology as well. Many doctors in the room, I'm sure, receive screenshots from their patients saying, "Doc, my glucose level has just spiked after a cup of coffee." I naturally reply, "Yes, great, that's hepatic gluconeogenesis, that's good, something's working for you." Or, "As soon as I step onto the treadmill, doc, my heart rate rises." Well, again, that's the sympathetic drive. Your vagal tone is down, that's good, just get fitter now. So we're facing this world where unstructured data in the hands of the individual is creating an overwhelm for them, and then, of course, translating that burden to the healthcare provider, which is only getting bigger and bigger and bigger. And we've seen some of this data before in previous presentations, so I won't stress the point. So what do we do? How do we potentially address this? So I'm going to present how we at Human Edge have thought about it. Might be right, it might be wrong, but it's our potential first step towards it. And we heard others yesterday and day before, and of course earlier this morning, of ways that we can do it. Now, I'm not an engineer, I'm not a technologist, so I won't pretend to address those aspects. What I'm going to take you through is, how does a physician look at a tool like this? How can it impact me and my care? And potentially for the other physicians in the room, something to think about how we could apply it to other practices as well. So we have 6 steps. Step number 1 is, as they said really well earlier today, Prashant and Raj, which is consolidation. How do you bring all of this data together, firstly, into the right place? So an individual today going through one of our programs, and these are just some of the data points on there, you know, as many of them have spoken about before, 200 plus bloods, 40 plus digital, functional points, genomic points, microbiome points, lifestyle points, etc. How do we bring that multivariate data stream into one platform for the individual, but also for the doctor, so that the doctor is not overwhelmed with reels of reports in paper or having to look at different digital applications or platforms to try and make sense of what's actually happening under the hood for the patient. So step 1 is consolidation. Step 2 is then the interpretation. All labs today in India have different ranges for different biomarkers. Labs across the world, we have patients across the world. We measure things with different units in different parts of the world. Different devices have different ways of measuring different digital biomarkers, and they classify, and the nomenclature around that is very different as well. So how do we create a standardized approach, at least within a practice, so that all of the healthcare practitioners in that practice can at least be working within the same guidelines, interpreting things within the same set of levels, and then hopefully prescribing the same philosophical output for the individuals as well. So this is step 2, the interpretation layer for the provider. Now we get to the recommendations. This is where one consumes information from the scientific literature and internal expertise to try and develop a methodology which means for the same patient, whether he or she is sitting in front of me or one of my other medical colleagues in the practice, will hopefully have the same set of prescriptions and therefore outcomes, so that the inter-expert variability can try to be reduced as much as possible. so that the patient is given the right guardrails around the prescriptions that are being created, and ultimately that it's as scientifically based on public literature as well. So the third element, therefore, is the recommendation layer. Now, we've now started to deploy this in the clinic. Everything I showed you has been sort of the work we've been doing over the last 18 months. And it stops short of pharmaceutical interventions. So these are just some of the stacks that we call it, the verticals that an individual may have recommendations being provided to the expert based on the various biomarkers which are being collected. And here comes the element of trust. The man in the middle model is the expert that needs to remain there for the time being to validate the information, giving the trust to the end user, but also ultimately training the system at the back end to do a better job going forward. Then we publish, this is what the individual looks at, a very simple screen based on circadian rhythms, which are all of the recommendations throughout the day based on the different stacks. And then depending upon compliance, etc., the doctor, the health coach can keep track and see outcome as well. And then finally, of course, there's documentation, because you want to be able to capture the information from consultations in a way, especially in a multidisciplinary practice. So these are the 6 steps that we've been employing. Now, what we've started to ask ourselves is, how does this compare in terms of clinical outcomes, right? Because that's what we care about the most in our patients. So I'm going to take you through very preliminary data of a cohort of 30 individuals who we've been using this as a methodology for, and looking at what the impact for that has been, not just internally in terms of productivity, but externally in terms of health outcomes as well. The first is the design of the study. So it was a cohort of 31, male more than female, age distribution 26 to 60 odd, and then BMI distribution as well. We decided, rather than looking at individual biomarkers, we went for health impact on specific systems. For example, an individual with a low B12 showing a hypochromic macrocytic anemia, we're not only interested in whether the B12 level will rise, but is that leading to a complementary elevation in the hemoglobin levels as well. So it's a more of a health outcome approach on a sigmoid curve rather than just biomarker impact alone. What we found at the 3-month mark, when we've repeated their blood chemistry, is that 30% of individuals have shown signs of improvement. Women, much more than men. Of course, there seems to be a dose dependency around compliance. And then there are people who have negative outcomes too, which are based on certain lifestyle events, like an acute infection, a family bereavement, work-related travel pressures, etc. So we're going deeper into this to try and unearth why some people are responding much better and others are not. Systemically, the hepatobiliary, the immune, and the cardiovascular systems are showing early signs of change. And then there are certain what we call medical tags, which I've highlighted here, the nutritional deficiencies being the most responsive, of course, and then leading to certain changes in terms of cardiovascular, aerobic, and stress markers as well. What do we do next? The next element is obviously to try and understand more of these patterns, but now triangulate this to the digital biomarkers that we're collecting. That's the first step. The second step is that in addition to this group of 30, which have been very human-centrically delivered, we have an additional group of 100 that have only been on this digitally. There is no human involvement. So we want to now start to see, is there a significant separation, and therefore how important is the role of the health expert, human, coach, or doctor, versus a more self-driven approach in leading to healthcare outcomes. And then the third aspect to this is then looking at where this goes in terms of scale. So I think I have a minute or so left, so I'm happy to answer any questions that would be there.
I was wondering, what are the areas where you think a platform like this cannot augment at all?
My wife and I had this conversation this morning. She's also a clinician. Empathy and care. 2 elements which, no matter what amount of technology you try to build in, that's something, because Because we must remember that this relationship, the doctor-patient, has gone back thousands of years, and most of it comes down to a simple piece, which is a human in their most vulnerable state is reaching out to an expert for some care. So we think about this a lot. We have this internal concept of design for trust and design for empathy as well. And I don't think we are going to become redundant anytime soon. I think it's about us ensuring that we stay relevant and innovate with the industry, but we continue to focus on the things we as humans do best, which is our hands and our ability to communicate and talk.